anxiety disorders, a drug for anxiety disorders, as well as antipsychotics, psychostimulants, and a little on Alzheimer's treatments. Um, Hopefully we'll have also time. I know many of you have some questions or concerns about exam 3, and hopefully I can touch on some of those at the end. So anxiety disorders, there are a number of different anxiety disorder diagnoses, and basically they have certain recurring themes, things that are common across the diagnoses, but often will differ in terms of like the actual presentation of anxiety. For example, generalized anxiety disorder, this is basically defined as anxiety symptoms like restlessness and difficulty concentrating, sleep disturbance, etc. But it's present at a fairly consistent low to moderate level most of the time. So think of this as just kind of a chronic low level anxiety. Whereas panic disorder presents with panic attacks. It's basically your anxiety ratcheted to a 10 in a very discrete, short, relatively short period of time. Here, panic attacks are defined as episodes where the person experiences kind of severe anxiety, palpitations, sweating, shortness of breath, kind of a loss of control and a fear of dying in some cases. And what can happen is that people with panic attacks or a history of panic attacks become anxious or apprehensive about having those attacks in the future in a kind of in a situation where they don't want to have it. In those cases, you can have what's called agoraphobia, where people will basically stay at home or kind of avoid being in situations where it would be inopportune to have a future panic attack. Social anxiety, basically you have panic symptoms or anxiety symptoms situationally bound to social or performance situations. So this is people who experience anxiety around being around strangers or other people, or public speaking or things of that nature. And then obsessive compulsive disorder is a syndrome where there is a mix of obsessive, intrusive, or recurrent thoughts. Compulsions are these ritualistic behaviors that are intended to kind of relieve the anxiety associated with the obsessions. And these can be stressful and cause problems, And then finally, PTSD or post-traumatic stress disorder. This is a fairly complex syndrome, but basically, to define this first, there has to be some sort of a traumatic event that the individual experiences. This could range from combat trauma for military veterans, or people with history of abuse, domestic violence, sexual abuse, that sort of thing. Or it can be natural disasters. So you have that defining traumatic episode, and then a series of symptoms, which can be flashbacks or intrusive memories related to the trauma, behavioral avoidance, where they try to avoid reminders of that trauma, and other sorts of issues around arousal, kind of increased startle response, etc. So all of these symptoms would occur as a result of that trauma for some period of time afterwards. So again, there are a number of things that tie these together. There's a pattern where there's an individual that exhibits emotional symptoms of irrational fear and worry. Keep in mind that these are they're defined as disorders because they're irrational, the fear and worry. There's a physical component where there's increased autonomic activity, palpitations, jitteriness. Also there's, in many cases, an identifiable genetic basis, and they have a lot of the same pharmacology involved in treatment. but they do differ in terms of the severity, patterns of anxiety disorders, chronicity, responsiveness to drug treatments and psychosocial treatments, and some of the underlying etiologies. Just to kind of orient you to, again, what underlies a lot of this, there's something called the fear circuitry in the brain, which involves the amygdala, hippocampus, thalamus. Basically, this is, when it's working appropriately and properly, this is basically your part of the brain that recognizes dangerous situations and prepares your body to react to them. In a perfectly normal anxiety-inducing event, for example, you're out in the wild and you're being chased down by a bear or whatever, you will perceive that stimulus, you will process it appropriately, and you will increase your autonomic activity so that you will prepare to fight or flight. In disordered anxiety, basically, this circuitry is activated inappropriately. So anxiety can be provoked by lesser situations that aren't supposed to provoke fear. So that basically is going to be some aspect of that circuitry is going to be disordered in all of the anxiety disorders, like panic disorder, where you have a high level of stimulus for the amygdala and exaggerated panic symptoms. Likewise, social phobia, where that is turned up to or is upregulated social anxiety situations, social situations. Generalized anxiety disorder, again, this is chronic low-level anxiety, so there is overactivation of that system, but again, it disconnects with what the stimulus is and what the response is. Fear circuit. Likewise, in OCD, you see that impairments in some of those connections, and finally PTSD, where we think that initial stressor leads to atrophy of some of the frontal areas where you're supposed to process these memories and responses, leading to a disinhibition of that person. All right, so with all that being said, really the way we address that is through one of two means. One is treatments that we can give chronically to gradually turn down that anxiety response, and that is typically with antidepressants. Very often, though, with antidepressants, you can often worsen anxiety before it gets better. SSRIs in particular tend to cause a little bit of jitteriness, a little bit of short-term anxiety, but over the long term, within 4 weeks minimum, you begin to see a reduction of anxiety symptoms. The other approach is to kind of put a blanket on the whole response altogether with CNS depressant drugs, and those would include benzodiazepines. They help with the physical and emotional symptoms of anxiety, but they obviously, as we've discussed the benzos throughout the year, they carry an abuse potential, and in particular PTSD, they can actually worsen the fear response. Yeah, sorry, really annoying. Yeah. Okay, that should be better. Again, just to as a review, we've covered benzos in context of seizure disorders and alcohol dependence. Benzos basically are what's called an allosteric modulator of the GABA receptor. So we talked about GABA last week, and again throughout pharmacology. GABA is a CNS depressant neurotransmitter, and when it binds to this receptor, it will basically facilitate chloride entry into the cell, and they basically make the cell less active, the nerve cell. Benzos do not bind to the GABA binding site, but they bind to a separate site kind of off to the side on that receptor, allowing it to actually facilitate transmission of GABA. So there are various subunits. Technically, there's what's called a gamma subunit of that receptor of that benzoyl. Basically, what these drugs do, and they will have different pharmacokinetic properties, but generally speaking, they will cause anxiolytic effect, reduces anxiety, and will cause a broad CNS depression. This slide basically lists the drugs. Again, the pharmacology is going to be the same across the class, but they will differ in terms of their pharmacokinetic properties. For example, half-life, which directly relates to duration of action in most cases, and their metabolism. So alprazolam, for example, is a drug that's given for its kind of short-term relief of acute symptoms, where something like clonazepam, because of its long half-life, is given more for prevention. If that's the intent for longer-term treatment. And then there are other drugs that are again more for preventative approaches, like buspirone, Buspar. This is a serotonergic agent. It works as a partial agonist at serotonin 1A receptors. It's only approved for generalized anxiety disorder, not for the other diagnoses. And basically, the response is going to be a little bit longer. Now, keep in mind, and I think I've emphasized it a few times, but I want you to kind of recall that with these disorders, there's going to be differences in terms of the expectation around response. And what I want you to know, as far as one of the learning objectives, is what to realistically expect. For someone with, say, an acute panic attack, and give them Xanax, you would expect their symptoms to resolve within 30 minutes, okay, because it's a fast-acting, broad CNS depressant. If we're giving Buspar for generalized anxiety, the expectation is that the onset will be in about 2 to 4 weeks, and the full that 6 weeks. Again, that's kind of the level of response I want you to kind of know in terms of timeframes. And that goes across all the disorders we're covering in these 2 weeks. Here is hydroxyzine viscoryl. This in the second line treatment. It's basically an antihistamine. Causes central nervous system depression, relaxed patients. Really not much else to say about that. It's H1 antagonist, so it causes sedation, and it has some mild anticholinergic effects as well. And then the SSRIs we talked about last week are generally what's used for all other anxiety disorders, and they have different expectations as far as treatment response and onset and such. I'm not going to go too much into the weeds with those agents we covered last week. Any questions? Our next group are drugs for schizophrenia and psychotic disorders. And you'll note with schizophrenia, it's a very complex disorder with a lot of different symptom domains. We talk about positive symptoms. These are experiences or symptoms that patients have that typically are not seen in the normal population, like delusions, false beliefs, or hallucinations. These are symptoms or things that are either seen or heard that are not typically experienced by people without psychosis. Negative symptoms, these are symptoms or deficits that are seen in people with psychosis that are expected to be present. For example, people with schizophrenia may have a blunting of affect, not showing affect or emotion, alogia, basically paucity of speech, volition, decreased motivation and ability to decrease experience and pleasure. There's also a cognitive domain and a mood domain that's also being that are also being recognized as part of this illness, and they all contribute to chronic social and occupational dysfunction, where people with schizophrenia often will require supports for just living in society. Some can function in full jobs, but very often with both the combination of positive and negative symptoms, often will it's very difficult to achieve example. Therefore, educational potential, learning potential, etc. Now, the reason why obviously the symptoms are important, but they also come into play when it comes to the pathology and then the psychopharmacology. This is a picture of the brain, and basically there are four pathways that are indicated here. And they represent different pathways for dopamine neurons in the brain. So what's represented by number one starts in the substantia nigra, projects to the basal ganglia. That's called the nigro-striatal pathway. That is the pathway that's involved in the pathology of Parkinson's disease. If you recall, Parkinson's is a neurological disorder where you begin to lose dopaminergic cells in this pathway, leading to movement disorders like tremor, bradykinesia, rigidity. This second pathway starts from the ventral secretion area and projects to the nucleus accumbens. This is called the mesolimbic pathway. The dopamine in this pathway, schizophrenia in particular, is present excessively, leading to the positive symptoms of psychosis. That's the mesolimbic pathway. Number three represents the mesocortical pathway, and we seem to think here dopamine is deficient leading to negative symptoms. And then finally, in the hypothalamus is a pathway where dopamine is involved in prolactin secretion. That's called the severocondylar pathway. So those are summarized in the next two slides here. So again, mesolimbic is where the positive symptoms come from. Too much dopamine, positive symptoms in the mesolimbic pathway. Mesocortical deficiency of dopamine leads to negative symptoms. And nigrostriatal pathway, although it's not really involved in the schizophrenia pathology, it's going to come into play with Parkinson's disease and then medication side effects. Likewise, it's a very particular pathway with medication side effects. So nigrostriatal is the motor effects. It's very particular, it's the prolactin elevation. So it's more than just a dopamine story, though. With schizophrenia, you have some of these other neurotransmitters involved, such as serotonin, glutamate, and acetylcholine. And there's some knowledge as to how some of these other transmitters contribute. Although in the case of serotonin, we do have some pharmacology, but really some of these other effects are more kind of theoretical at this point. We don't really have drugs that directly target glutamate and acetylcholine yet, although there's many that's being developed. All right, so just tie this all together. Antipsychotic drugs. Basically, what we have, primarily what's going on is excess dopamine in the mesolimbic pathway that causes the symptoms of psychosis, hallucinations, and delusions. And the first antipsychotic drugs, starting with chlorpromazine in the 1950s, and dozens of drugs that followed that, really work by decreasing dopamine in that pathway. And that's basically the simplest explanation for how antipsychotics work. Now, we can branch off of that. There are second generation drugs, newer drugs that are also called atypical antipsychotics They are also dopamine blockers, but they also involve serotonin blockade as well. And basically the therapeutic effects from antipsychotics from the mesolimbic pathway. Okay, so when dopamine is blocked on that pathway, you get really positive symptoms. That's what we want. Now, unfortunately, the drugs are not selective in terms of where they block dopamine, at least in the case of the first generation antipsychotics. So we can actually see kind of unwanted effects from dopamine blockade in some of these other pathways. And in the case of the mesocortical pathway, you're already starting out with a deficiency of dopamine. You can worsen that, worsen the negative symptoms from mesocortical dopamine blockade. Likewise, in the nitrostratal pathway, you get motor side effects of Parkinsonism or called extrapyramidal symptoms. And there, under the pathway hypothalamus, we get an increase in prolactin plus prolactin elevation, leads to breast enlargement, infertility, problems with the menstrual cycle, sexual dysfunction, etc. So there are hormonal effects downstream that result in prolactin elevation. So again, first generation agents. Primary from pharmacology is a block of dopamine. Here are a list of the drugs in that class. This column represents a potency comparison. Chlorpromazine was the first of the drugs that came to the market, and it's typically kind of represents the standard in terms of how the other drugs are compared in terms of potency. So 100 milligrams of chlorpromazine is considered or is equivalent in terms of potency in terms of dopamine blockade to 2 milligrams of Haldol, 10 milligrams of phenazine, etc. Meaning, haloperidol and phenazine are going to be your higher potency agents, meaning less of those drugs or fewer milligrams of those drugs to produce the same effects as 100 of promazine or 100 thyroids, which are low potency drugs. Now, the drugs aren't going to be as selective as we want for dopamine. They will block other receptor systems, including norepinephrine, serotonin, histamine, acetylcholine, muscarinic receptors, and it leads to side effects again, which you should kind of be able to predict based on the fact that we know what happens when you block histamine in the brain, what happens when you block acetylcholine. Acetylcholine, histamine, or so these effects are, other than the EPS, are effects that are produced from some of those other receptor systems. Unrelated to the receptor effects are some of the other side effects such as cardiac arrhythmias, photosensitivity. And then, but I also want to call your attention to the black box warning for antipsychotics related to dementia-related psychosis, where it's supposed as providers, you're advised to be very careful with the use of those drugs when you're treating behavior disturbances and dementia. There seems to be a linkage between antipsychotic use and dementia, such cardiac death. So this is basically a comparison of the side effect propensity for each of the first generation antipsychotics. They're high potency agents, stronger for dopamine, and therefore will have more of the EPS. That is adenosine and aldehyde. The high potency agents give you more EPS. Your lower potency agents are going to give you more of the other effects from oxidation. So again, it just helps to know what's on the extremes. So the high potency benzene alcohol, low potency thyroid. And then in a way, kind of everything else falls in. Here are P450 interactions. Really, these aren't narrow therapeutic index drugs, although you can obviously get into toxicity with too much. But really, the big rule of thumb is that the 2B6 inhibitor drugs may enhance the effects of it. This is just a slide on pregnancy. Here, but basically, they're the older antipsychotics like the one category C. I'll talk about the one. The newer antipsychotics, second generation, or atypical antipsychotics. They're listed here. Now, since their pharmacology is way more complex, it's not just, dopamine blockade and various things that come off of that. We don't necessarily compare them in terms of their potency, like apples to apples. But you see there are different dosage ranges. They're chemically distinct from each other, and to a degree pharmacologically distinct as well. And as far as these drugs are concerned, there's clozapine, first one listed, and then everything else, meaning that most of the drugs are considered equivalent in the treatment of psychotic disorders. Whereas clozapine has a distinct level of efficacy in treatment resistance, right? People who fail treatment, multiple other medications that put on clozapine for kind of as a second killer. It seems to be more effective in that population than most. So how did these newer generation agents improve on the old ones? For one, they have a much lower risk of extrapyramidal symptoms. So when you dose Seroquel or Risperidone, the expectation is that as long as you're within the therapeutic dosage range, you have a much lower risk of developing extrapyramidal symptoms. Stiffness, rigidity, bradykinesia that looks like Parkinson's disease, it's going to be low. However, they do carry risks that the other drugs really don't around metabolic syndrome, so that can cause weight gain and blood sugar issues. And they will have a lower risk around the worsening of negative symptoms and prolactin elevation, because they involve adding serotonin blockade. And again, I don't want to get too much into the weeds. There's a lot of pharmacology underlying this, but basically, when you block serotonin, you in the pathways listed here. Those are the three pathways responsible for the dopaminergic side effects. Mesocortical hydrostriatal is very familiar. And he said that you get worsening negative symptoms, EPS, prolactin elevation, and antipsychotics work in those pathways. What serotonin blockade does is help offset that and get more dopamine there. So basically, you get less of those side effects from atypical or second generation antipsychotics. There are other aspects for certain individual drugs, like what's called fast association, so that the drugs aren't as sticky to the receptors. You see that with clozapine and clozapine, and you also see partial agonism. In fact, at the beginning of the year, we talked about partial agonism, where the drug binds to the receptor and it does not send the full signal downstream. Aripiprazole, Abilify, and brexpiprazole, Percocet also have these partial agonistic effects, which make it behave like an antipsychotic. So you have those issues. Again, there's lots of distinctions between the drugs in this class. It's not just all dopamine blockade with different levels of potency here. We're dealing with multiple receptor effects, multiple aspects in terms of binding the receptor. Here is the clozapine. We said that it's effective for treatment-resistant depression, treatment-resistant schizophrenia, but it carries additional risks around. Key one is agranulocytosis, but it can also cause myocarditis, is a cardiac irritation, lower systemic threshold, states of blood pressure. It's very potent anticholinergic, so you have sedation. I've had recently around bowel obstructions in one of my clozapine patients. So those are all going to be major concerns. Sedation because of its potent antihistaminic effects, and then sialorrhea. You'd expect a anticholinergic drug to cause a dry mouth, but clozapine, unlike the anticholinergic, cause excess salivation. So you get that effect. So again, focusing on the blood dyscrasias, you get a drop in the white blood cell count, and you have to monitor that actually quite frequent. The first 6 months of treatment for clozapine, you have to be on weekly CBC blood draws. So you're getting that neutrophil count, and you are trying to make sure that it is within a range. It's going to differ. There's something called the where people with certain backgrounds will have a lower threshold for neutropenia than the general population. So these are just other kind of treatment perks. If you end up working in mental health, you'll get a lot more background on. Side effects. Here are the effects of second generation antipsychotics again. The mesolimbic pathway is the main therapeutic antipsychotics, but you get a lower propensity towards the side effects from these other pathways. We don't get worsening negative symptoms. We don't have the same degree of EPS, although you can get EPS with some of these drugs like risperidone. And then you don't get a prolactin activation. That's what the there are and the receptor profiles have said that they involve protein and serotonin primarily, and they can also involve some of those other receptors that cause side effects. That's there. Really, the key thing to note, one is that clozapine gives you that risk of the white blood cell, agranulocytosis, and then broadly across the antipsychotic class, second generation antipsychotics, you're at risk for metabolic syndrome. So that is an issue around weight gain, increase in insulin resistance and potential diabetes, and then increase liver. Again, the black box around increased risk of sudden death and complication. Is to have a table that considers the average of risk across the category of antipsychotics. See, again, they're each of these drugs, for the most part, are very distinct pharmacologically and chemically. So see kind of a range. There's no particular pattern I can kind of point out to you, because they're all very distinct. For 15 introductions, I don't be too concerned about, but if this was my Psych NP class, I would go into my whole spiel about 182 substrates where we remember, we kind of touched on this last time, cigarette smoking reduces this 182 enzyme, which means increase your clearance of clozapine and olanzapine. You know the incidence of nicotine dependence of cigarette smoking amongst schizophrenics, 75%, a very high rate of smoking. So they people on clozapine and olanzapine often decompensate if they are going from non-smoking hospitalization to smoking community on their medication. So there's that whole thing. You have to kind of anticipate that.
Why would you do it? Like not
in the case of clozapine, because they're treatment resistant, you have no other option. And olanzapine actually, Zyprexa, actually is, has a lot of good benefits in terms of being effective for schizophrenia. But you might just need to increase the dose once they're out in the community. This is fairly important. What I want you to kind of take away in terms of formulations, that in mental health, we have to be concerned about, I mean, it's really complex, but compliance or adherence to treatment. You have a number of reasons why people with mental health issues are uncompliant, will refuse or forget to take their treatment. Some of which relate to the symptoms of the illness itself. Some people don't mind being psychosis or that. Others will have cognitive issues associated with their illness that cause them to forget or be disorganized in terms of their medication use behaviors. And there's others who just have poor insight, that don't realize that they are ill or don't believe that they're ill. And all of those will combine to really undermine medication adherence. So there are drug formulations that are designed to enhance adherence both in the hospital and in the community, such as orally disintegrating tablets. These are formulations when applied to the buccal membrane of the mouth, they dissolve very rapidly and make it difficult for patients to kind of conceal or cheat their meds. And you see a number of examples of second generation antipsychotics that have exposure to the orally disintegrating formulations. Injectables can either be short-acting or long-acting. Short-acting injectables are for acute symptoms, agitation or aggression. This is not for, say, long-term management of psychosis, but if you have someone that's psychotic or maybe even manic that require treatment for an acute agitation or behavioral episode, short-acting injectables, powerful, medicine, pharmacy, plans to bring the passage out now as well. That. And then the longer-acting formulations are designed to kind of almost serve as a substitute for daily oral dosing. So in the case of haloperidol and prednisone, they're formulated as called the canoate esters. You take the drug and put a long fat-based chain on it and inject it deep into the muscle. It will slowly release the medication for several weeks and basically have antipsychotic levels on board without having to take oral meds. So in the case of Haldol, we dose it every 4 weeks, prednisone every 2 to 3 weeks. Newer second generation drugs tend to have more advanced formulations that are water-based, less painful to give via injection. Lots of different examples of those listed there. And their dosing intervals range from 2 weeks to reading. There's actually a 6-month formulation of paliperidone as well. So it, basically, you have a wide range of dosing intervals. And again, the idea here, you discharge somebody, they're not going to necessarily be diligent about taking their meds every day. It's long-acting effectiveness, help address that. So, I have an objective around pharmacological formulations with these psychotropic drugs. So just keep that in mind, both with antipsychotics for managing adherence, and then there are ADHD adherence formulations as well. Right, so attention deficit hyperactivity disorder. Childhood onset disorder that's characterized by age inappropriate levels of inattention, loss of or a lack of ability to kind of focus and remain on task. That can be seen in conjunction with impulsivity or overactivity, kind of behavioral aspects. With ADHD, symptoms occur across settings, so it's not just at school setting, and it results in functional impairment. Symptoms will begin in childhood, but can persist into adulthood. They're not going to look the same in adults as they do in children, but there can be changes in ADHD symptoms across the developmental timeline. I'm not going to read all these to you, but basically this, there are, right now in the current diagnostic criteria, 2 primary domains. The inattentive domain, where people will just not have the ability to sustain attention or focus or remain on task, results in problems with organization, executing long, complex tasks. And then on the hyperactivity impulsivity domain, where there's an elevated kind of motor activity, fidgeting, squirming, running around, talking a lot, and acting compulsively, where folks will not necessarily shame or think through the consequences of behaviors, interrupt, improve on others, etc. Story with ADHD involves dopamine and norepinephrine, and we think that one or both of those transmitters are going to be deficient, specifically in the frontal area of the brain. And even in normal functioning, the frontal lobe is one of the last areas of the brain to mature, and those pathways are particularly poorly developed in younger patients with ADHD. So dopamine deficiency basically involves impairment in attending to tasks, regulating mood, and resisting distractions, and with norepinephrine deficiency leads to modulating attention arousal. How do you reverse that? Quite simple. We use stimulant drugs. Stimulant drugs are agents that are actually very effective in causing an improvement in dopamine and norepinephrine release in the frontal lobe. And in doing such, you can actually see a fairly rapid improvement, a robust improvement in ADHD symptoms within days of treatment. So stimulants specifically will cause release of norepinephrine and serotonin from presynaptic vesicles. We talked about last week serotonin in terms of serotonin reuptake inhibitors. In the presynaptic cell, you have these little bubbles or packets of neurotransmitter that goes to the presynaptic neuroterminal and then release the contents. into the synapse and then activate the next cell. Basically, the stimulants do the same, well, yeah, they follow the same process with dopamine and norepinephrine, but they really facilitate the release of those transmitters from those synapses. So basically turbocharges the release of those catecholamines, norepinephrine, dopamine. And in terms of their kinetics, short-acting agents will be absorbed fairly quickly, and you will notice effects within 30 minutes after it transits the GI tract and the drug gets into the rectum. They have other properties which makes them work completely as well, such as low protein binding and fairly short duration of action because they're rapidly broken down bloodstream. So the effects of stimulants on ADHD are, again, pretty robust in most patients. You see an improvement in inhibitory controlling behaviors, so they have less impulsive acting out and more kind of, at least some ability to kind of think and modulate what it is they should do in reaction to what's going on around them. The attention measures are going to be significantly improved where they have more on-task time. They have better efficiency academically, where if they're given kind of, academic tasks, they'll spend less time on it because they're able to do so without the distractions they would otherwise experience. And then on social skills, and other related outcomes, there seems to be benefits there as well. In the long term, we don't quite have the same sense, although there is some thinking that you're more likely to, get to your academic outcomes that you're expecting and hold the job and do those other things, although those studies really haven't been definitively carried out. Now, specifically, the drugs used as stimulants are one of two chemical classes, either methylphenidate derivatives or amphetamine derivatives. Methylphenidate derivatives include methylphenidate itself and dexmethylphenidate, which is basically a isomer. And then the amphetamine derivatives include dextroamphetamine, mixed amphetamine salts or Adderall products, and then a newer product called dexamphetamine, which is Vyvanse. So in that first group, the methylphenidate derivatives, we have Ritalin, which is the branded product of methylphenidate, and then all the other kind of congeners of that, formulations of methylphenidate. And then you have dexmethylphenidate, which is an isolated enantiomer of the most active isomer of methylphenidate called focal. So both of these are going to produce very similar effects. Very fast onset of action, with short-acting products are, 3 to 4 hours in terms of duration. The dosing is listed there, although I don't hold you responsible for that. But what you do need to know is that the dexmethylphenidate has a potency of, kind of a 2 to 1, because it's the most active isomer of the racemic version of methylphenidate. Then the other group are the amphetamine derivatives. Again, mixed amphetamine salts, Adderall, dextroamphetamine, dexedrine, and this dexamphetamine Vyvanse. Basically, they will have similar effects on dopamine or norepinephrine, but if you were to really measure areas of the brain that kind of light up on, say, a PET scan, which we don't do clinically, but you can see some subtle differences in how individuals respond to amphetamine versus methylphenidate stimulants. And that particular fact informs our treatment guidelines, which state that if you fail a stimulant in ADHD, you should switch to a stimulant with other pharmacologic class. Meaning that you might just have a patient that's more sensitive to amphetamine versus methylphenidate or vice versa. So which is why I kind of present the drugs this way. Methylphenidate versus methylphenidate. If you don't do well on Adderall and you switch to Vyvanse, you have a much lower likelihood of getting that additional efficacy as you switch to a different category. Some highlights here. Adderall basically contains 4 salts of amphetamine. It's called mixed amphetamine salts. Amphetamines in general give you a slightly longer duration of action compared to methylphenidate. This dexamphetamine is notable for its binding of lysine, which is an amino acid, to the amphetamine. You give that drug by mouth. You need to have that lysine removed from the drug in order to then release the active ingredient. There's a lot of abuse around stimulants in terms of diversion and misuse, trying to inject the drugs, etc. And this dexamphetamine serves as an abuse deterrent in that you need to take it by mouth in order to get the amphetamine released from the parent drug. So this prodrug is not going to be effective if you give it by injection versus giving it by mouth. So it makes it somewhat of an abuse deterrent. Okay. So again, getting back to the issue around formulations and treatment adherence. ADHD, this is a condition where the patients are primarily young, pediatrics. They go to school during the day. And over the course of the day, there may be a need for coverage, when I say coverage, symptom control, certainly during the school day, but then in some cases in the early evening, late afternoon, early evening, when kids have after school activities, etc. The drugs are such that you take it, and in the case of methylphenidate, they're going to be effective for about 4 hours, meaning you will have a notable improvement in non-task behavior and reduction of hyperactivity for as long as that drug is active, and then the effect wears off. What then you would have to do, if you need coverage, say after 12 o'clock, then you give another dose. There's some stigma associated with having to go in the middle of the day to the school nurse to get your medication or whatever. So between that and some of the other adherence issues, there were quite a push actually for controlled release agents, which you can give once a day. The problem here, or the challenge, let me put it that way, is that just having a drug released gradually over the course of a 10 to 12 hour day is not going to be sufficient for stimulant drugs. What you want is kind of a rising level. And so the drugs, as long as the blood levels are increasing, will maintain their efficacy. As the levels are decreasing, meaning the absorption phase is over and it's really more in the elimination phase for immediate release products, you begin to lose that efficacy. So what we do now with modern controlled release formulations is try to extend the absorption phase as long as possible. So as long as the drug is transiting in the GI tract, we want the blood levels to increase. So this diagram is a cross-section of a formulation called Concerta. Concerta is the controlled release methylphenidate. It works through an osmotic system. And again, the leads are really detailed. I don't want to, get you too much into that. But really, the important thing here is that the result of a administration of something like Certa is that it produces multiple peaks. So if you take an immediate release drug, blood level goes up, and after a few hours, it begins to go back down, and then you have to repeat the dose, it goes back up again, it's back down. As long as those blood levels are rising, you're in the good zone in terms of practicing. So with these products, basically can produce a similar curve, but just by taking one pill in the morning. So with methylphenidate, you have an outer coat that will release immediately, and then what's called a osmotic pump that's built into the tablet, where when the drug is now in the stomach and there's fluid, it's mixing in. Basically, there's a tiny hole drilled in the tablet that literally pushes out a second bolus of the drug, so that when you take one dose of it, you begin to get a second peak of the drug. And so basically, it's a technology that will unit twice or multiple times daily dosing with just the one tablet. And ideally, you will get coverage throughout the course of the day. Now, that wearing off by the time the evening comes, where you don't get into some of the stimulant side effects persisting into the evening. Here are the formulations, again, dosing or specifics around the duration, but you know, if I identify, say, something like Certa has controlled release methylphenidate, you should at least know what the concept we're looking for is. That slide. There's also a skin patch of methylphenidate called Daytran under it to apply it to the skin in the bed, and then remove it when you want the effects to wear off. Really 2 hours before. What's important to note are the side effects. So stimulant drugs, they cause norepinephrine dopamine release, they're activating agents. What they will do in kids and adults is actually acts appetite suppressant. So you feel less hungry, you don't want to eat, and you ultimately will end up consuming less calories because of the appetite suppressant effect. So now how this plays out in practice is that ideally your patient will have, you know, good breakfast intake in the morning before they take their meds. They take their stimulant, and basically you try to get in what you can get in during lunch. Realistically, a lot of kids will not necessarily have a great appetite around midday while the stimulant is active, but the expectation is by the time dinner comes in, they're able to have a normal intake around dinner. And really, that's the best case scenario. So there are some other strategies you can do to help with that. There's what's called drug holidays, where you stop the stimulant over the summer months or on weekends, you know, on days where you feel you might not need to have that medication on board. So you can manage the appetite suppression, and it's called also the slowing of the day curve, because you get less calories and you tend to see a slowing. Doesn't mean they won't reach their growth potential. It just takes a little while. Kids on stimulants. Some other issues, these drugs can cause headache, jitteriness. They can cause insomnia. That's another significant risk because they're activating, disrupt sleep. So again, you want the drug to wear off in the evening so that you can get normal sleep pattern. Although one of the underlying pathologies for the ADHD is a latency. It takes time for people to fall asleep, so we have those issues. They're dopamine releasers. So with psychosis, we talked about increased dopamine and the pathway causing hallucinations. Well, technically, this is a risk around stimulant drugs because they can cause dopamine release in that pathway. It can also worsen anxiety for a bunch of the same reasons as they increase norepinephrine activity. And these drugs are scheduled to control substances as a high risk of abuse. There are a handful of non-stimulant drugs also for ADHD, such as atomoxetine, Stratil, inhibitors of stimulant light, which will give you the same benefits, but with a lower effect size doesn't seem to give you the same overall robust effects that you may see with stimulants. But it can help for the main symptom domains, inattention, hyperactivity, and impulsivity. The onset of effects are usually within a week, and the pharmacology is that is a norepinephrine to be out there. Direct releaser of these transmitters, but more kind of increasing active. We have to very much talk about it. Here are the kinetics, a lot of the side effects are, similar to stimulants. You get some weight loss and appetite suppression. You get some jitteriness, increased blood pressure, pulse, some insomnia, etc. But again, not to the same degree as the stimulants. The next group of drugs are adrenergic agonists. These what you'll recognize from our hypertension unit, clonidine, guanfacine. Basically, they have inhibitory effects on the locus coeruleus by blocking alpha-2 norepinephrine receptors. Sorry, it's agonists on alpha-2 norepinephrine receptors. They're good for reducing impulsivity and hyperactivity, but they don't really have the same benefits on attention and focus. Here are specifics on clonidine, guanfacine. Not surprisingly, they will lower blood pressure because hypotension is sedation, and when you stop these drugs, they rebound hypertension. Non-stimulants. Our final area for today are drugs for major neurocognitive disorders or dementia. Alzheimer's disease is really one of the main indications in this area that the drugs have been studied for. This is a gradual progressive dementia that occurs over many years, typically in older people. The domains of cognition, behavior, and functional status will see a slow decline over time. There's no cure that's known for these disorders. And what the medications do, at least the ones that are on the market nowadays, is kind of reduce the progression, kind of slow the progression from mild to moderate to severe, but really nothing that we have reverse that course. And really the underlying pathology is a loss of cholinergic neurons in the hippocampus area. The hippocampus acetylcholine there is involved in cognitive functions, particularly memory. And when you have loss of those neurons, pathways to get memory loss, which is the hallmark of dementia. There is also a glutamate story as well in terms of this disorder, where there's a release of glutamate causing cytotoxic damage with calcium. And one of our drugs will work to modify glutamate transmission also. Now, from an anatomic standpoint, there is changes in the brain structure that is quite notable. On the left, you see kind of a full healthy brain with gray matter and white matter. Basically, these empty spaces and these folds become much more prominent in areas that modulate language and memory. And these sulci, which are the folds in the brain, become more prominent. So basically, there is widespread cell death and degeneration of these cells, leading to the dementia behavioral symptoms that we see. Under a microscope, you'll note that there are these plaques that build up called beta amyloid that build up in the spaces between nerve cells. So that is these amyloid plaques. And tau protein from the neurons will get twisted, causing what's called neurofibrillary tangles. That's what happens in terms of pathology. The amyloid plaques, interestingly, at the very end is, I'll discuss one treatment that really targeting that. But really, most of our drugs look to correct the neurotransmitter deficits. You see the point that we see in Alzheimer's. Just very briefly on the types of dementia, vascular dementia. It's of cognitive deficits and cognitive loss after a vascular event, like a stroke. So there, the course is a little bit more jagged, whereas Alzheimer's is kind of a gradually declining course. When you have a stroke of the brain, you don't have any recovery there. You can see kind of a drastic drop in cognition and other functional changes, language, motor activities, etc. And then dementia with Lewy bodies has a different pathological finding. Lewy bodies literally are areas of the brain that are distributed throughout the cortex that lead to cognitive impairment. And this basically looks like dementia with Parkinson's. So again, because we don't have curative treatments, our goal is to manage cognitive difficulties, preserve function as long as possible, and then to the extent that it's safe and reasonable to do so, try to treat the behavioral issue. So patients with dementia often have problems with paranoia, and wandering, and other sorts of behavior changes where it may or may not be appropriate to treat with medications. Of course, anything that worsens cognitive issues, particularly anticholinergic drugs, should be stopped. So that's an important point. If you're ever doing nursing home consulting, you have people with dementia and behavior changes, look for any anticholinergics. Try to find out the alternative drugs. Cholinesterase inhibitors are the primary category of medications for Parkinson's disease. They include drugs such as donepezil, rivastigmine, and galantamine. They basically inhibit the breakdown of what's left of your brain's acetylcholine. So the cholinesterase inhibitor, they block the breakdown of acetylcholine, basically will maintain acetylcholine levels in the brain a little bit longer. That will activate the selective acetylcholine receptors and try to slowly the worsening of cognitive decline. This slide basically diagrams how these drugs work. Then presynaptic cell on top, postsynaptic cell on the bottom. Acetylcholinesterase basically breaks down the acetylcholine to choline acetate. But when you block that enzyme, you have more acetylcholine that activates the receptor. It's basically the same story as we talked about MAO inhibitors last week. Basically, an enzyme that's in the synapse that would normally break the transmitter down, but you're inhibiting that enzyme. So it's going to be more. Cholinesterase inhibitors, three agents on the market. There was an older one that came before donepezil, that's been removed because it was for the issues, particularly liver toxicity. But these are three that remain: acetylcholinesterase and butyrcholinesterase, in particular, is the target for rivastigmine. They all will be approved for mild Alzheimer's. Rivastigmine, donepezil, goes on to has demonstrated effectiveness for moderate to severe disease as well. You see the differences in terms of enzymes that are involved in metabolism. Really, the effects between the differences between these drugs aren't particularly meaningful. You know, the mild to moderate indication for donepezil probably is just a reflection of the fact that we don't have a lot of studies in severe Alzheimer's. But generally speaking, you put someone on this and you keep them on it for as long as it's beneficial. These drugs are strocholinergic. And wouldn't be surprising to learn that they cause increased GI motility. Anticholinergics tend to be constipating. Acetylcholinesterase inhibitors tend to cause diarrhea, the opposite thing. We minimize GI toxicity by giving it the food and allowing the patient's body to fitness to it. Worsen peptic ulcers, called bradycardia. Again, not surprising based on what you know about pharmacology. Drugs that promote muscular and acetylcholine effects tend to slow the heart rate down and the sinus need. And then the interactions again. Not a lot to be surprising that around anticholinergic effects, which will offset the effects of cholinesterase inhibitors, but then also P450 related interactions with phenitone, carbamazepine, erythromycin, etc. So, pharmacology and pharmacokinetic interactions, that's what that makes sense. The other oral drug for Alzheimer's is memantine or Namenda. This is an anti-glutamate drug. We said that excess glutamate contributes to neuronal cell death in Alzheimer's. And basically, this drug opposes the effects of glutamate. Memantine inhibitors are indicated for moderate to severe cases of Alzheimer's disease. And it has a fairly straightforward pharmacokinetic pathway for the pharmacokinetic profile of the long 68 time. Generally well tolerated. Here are some side effects in GI, some CNS. Interestingly, what some folks have noticed is that with memantine, you get an initial worsening of confusion because you have someone with Alzheimer's now getting more awareness of what's going on around them, and their underlying dementia kind of makes that jarring. That's correct. But generally speaking, again, your expectations that this will help slow the overall decline. And then finally, the anti-amyloid agents. These are newer drugs. I'm saying newer, introduced within the last 3 to 5 years. They're basically monoclonal antibodies directly against the beta amyloid plaques in the brain. Alzheimer's disease, again, when you look under the microscope, you see these amyloid plaques in these nerve cells. Basically, these antibodies will bind to the plaques and help dissolve them. You would think that the helpful thing, but really in this, the effects that have been shown with these agents aren't terribly impressive. You might get some, 3 more months of cognitive functioning than you would otherwise. And this, of course, comes at a very significant cost as we've seen with drugs, upwards of $26,000 a year. And really the big controversy with Medicare, do we put a bill for taxpayers to pay for, people with advanced Alzheimer's just to get this very minimal benefit in terms of their cognitive function. So I believe this currently still stands as policy, but they will only cover this drug for patients who agree to have some of their data used for more long-term studies. So really, it's not covered unconditionally because of the high cost of the benefits.